Good afternoon, ladies and gentlemen. A very warm welcome to you all. Thank you for taking the time to come and join us in today's discussion. My name is Catherine Namara, and I will be your moderator for today. Today's topic is a very interesting one. It is Saving Mothers Together, a multidisciplinary approach to vaginal bleeding related emergencies. This is one of those scenarios where every second counts, and it's imperative for us as health workers to be able to arm ourselves with the knowledge and the skills to navigate these scenarios with ease and ensure the best outcomes for our patients. So once again, I thank you for taking the time to join us for today's eco session. Before we start, a few housekeeping rules. We'd like to keep this session as interactive as possible. So I'd like to encourage you all to make use of the chat section. In case you have any questions, please feel free to drop them in the chat and we'll respond to those as we go along. In addition, we'll also be sharing a few poll questions every now and then. I encourage you to engage with those, give us your opinions and let us know what you think about the different questions. It will give us a baseline and an understanding of what the audience knows and how much our experts need to go in detail. And finally, this is a session that's being recorded, so you'll be able to have access to this material and review it later. So without any further delay, I'd like to give an opportunity to our wonderful panel of experts to introduce themselves. I'll start from my extreme right, and then we'll work our way, extreme left, sorry, and then we'll work our way down to my right.
All right, thank you so much, Dr. Kathy. My name is Asima Janice. I'm an EMT with the background of midwifery, and I'm the ambulance coordinator at St. Francis Zambia Hospital. Happy to be here.
Thank you, Janice.
Thank you so much, Catherine. My name is Solomon Wani, and currently I'm a student at Makerere University pursuing a master's of nursing in midwifery and women's health. I also do have an awesome privilege of teaching at Lira University as a teaching assistant. Thank you.
All right. Thank you, Solomon.
Thank you very much, Kathy. Good afternoon. I'm called Captain Oles. I'm a resident of Hopes and Guys at Makerere, serving at Kawempe Women's Hospital, and also have a privilege to serve at St. Luke Health Center for Mtungo Bina. Thank you.
All right, thank you. Joining us online, we also have two other experts. I'd like to give Dr. Sarah an opportunity to introduce herself.
Hello, I hope you can hear me fine.
Yes, we can.
Great. Good afternoon to all of us that are online and those in person. My name is Dr. Orina Wesara. I like being called Chavaje. I am one of those few that have opted to work in the remote places of Uganda, and I enjoy it. And I'm glad to join us online today. I will be handling the chat questions.
All right, thank you, Dr. Sarah. And finally, we'll have Dr. Janice Akedo, Dr. Jacqueline Akedo introducing herself.
Good afternoon. Are you able to hear me? Okay, so this Dr. Jacqueline Akelo Obsgyn. I teach at Makerere University. Apologies for not being there physical. I'm a 2 weeks old Nakawere, so unable to move, but happy to be here. Thank you.
Great. Thank you, Dr. Jacqueline, and thank you to all our brilliant experts. We're very excited and eager to hear from you. Now, to kick us off, I'd just like to hear from a few people in the audience to tell us what their expectations are from this session. Anyone present in the chat, feel free to raise your hand and we'll be able to give you an opportunity to unmute and let us know what you would like to learn from this session. You're also free to type within the chat. We'll be able to see those comments. Okay, anyone in the audience, please feel free to raise your hand. Let us know which one or two things you'd really love to hear during this session and what would make this session worthwhile. to you. Okay, so I will be selecting somebody to give us their expectations. I can be with Simon. Please unmute yourself and tell us what you would like to learn from this session.
Yes, thank you very much, presenter. Good afternoon to you, everyone. My expectation is maybe probably the best and current control measures of PP bleeding in our pregnant mothers.
All right, thank you, Simon. Dr. Said Hajir has requested to share his expectations. In the meantime, as Dr. Said is being unmuted, Andrew Okiro would like to learn about fluid resuscitation. Maximilian Mwima would like to know about the most common causes of vaginal bleeding in Uganda. Caroline Nampeo would like to know about the early signs that prompt her to worry, other than obvious bleeding. Thank you for sharing those. Yes, Said. All right. We'll proceed for now. We'll start our discussion off. Oh, sorry. Yes, Said, go ahead.
Yeah, thank you very much. I'm very glad to be here today afternoon. Everyone, I have to say first, good afternoon. I'm joined. Sorry for small interruptions because we have a network problem here in Somalia. So I wish to know more about the significant signs of PP bleeding in not only Uganda, in all Africa. Okay, so we can proceed now. Thank you very much.
All right, thank you very much. It's wonderful to know that we're being joined by people from all over the world. Thank you all for coming. So to begin our discussion, we'll have Dr. Kalute taking us through a case presentation, just a basic snapshot of what these scenarios can present as. Dr. Kalute, the floor is yours.
Thank you very much, Dr. Kathy, for the introduction. And thank you for our audience for keeping time and being online. Kalte Lawrence, once again, I'll be taking you through the case presentation for this session. Yeah, a brief history about the patient we have for this presentation. J.E., 41-year-old female, Mary Paras, presented with 9 days history of PV bleeding that started 2 weeks after her normal menstruation period. And this involved the expulsion of clots and fresh blood, which was associated with low abdominal pain. She had palpitation, she had dizziness. However, she didn't have any difficulty in breathing and she didn't have headache. So from our primary survey, this patient had airway was patent, breathing. She was not in any obvious respiratory distress with a respiratory rate of 18 breaths per minute, normal resonance on percussion, and normal equal air entry bilaterally. She had an SpO2 of 95% on room air. Circulation, she had cold extremities and she had a capillary fill time greater than 2 seconds with a pulse rate of 108 beats per minute, a BP of 90 over 55 millimeters of mercury. She had active vaginal bleeding. The disability she had, she was alert with a Glasgow Coma scale of 15 out of 15. The pupils were equal and reacting to light, and she had no focal neurological deficits. She was a febrile, severe pale, with no visible skin rashes.
Right. So, audience, we have our first poll question that is being projected and is also going to be shared in the chat. From the primary survey, what is the emergency condition? What are the emergency conditions in this patient? So Dr. Kadute has presented to us a scenario of a 41-year-old female with a 9-day history of vaginal bleeding. He's gone through the primary survey, that's the ABCDE approach. And here we have a question asking you to identify what the emergency conditions are. Okay, keep those answers coming in. Okay. Let us know what you think. What stands out in the scenario that's been shared as an emergency? Okay, to everyone that's responding, thank you. And everyone who hasn't responded yet, please keep sharing. We're almost there. Just a few of you need to respond and we'll be able to close this poll in the next few seconds. All right. Thank you for your responses. Dr. Kadute, you may proceed.
Thank you. Those who have responded. So what are the emergency priorities in this patient? Our threats were in the circulatory system, and the emergencies we had here hypovolemic shock, secondary to active vaginal bleeding, and the findings to worry us were the cold peripheries and a capillary refill time greater than 2 seconds, the pulse rate of 108, and the BPs that were crashing. Then we had active bleeding of vagina. The associated risks with these findings are multiple organ failure and cardiac arrest.
Okay, and right there we have our second poll question. What is the emergency management priority for this patient? So we've had the history of the patient, we've looked at the primary survey, we've identified the emergency conditions, and now the question to you, audience, is what emergency management priorities would you have for this patient? So in the poll there, we have a couple of options. One is IV ferrous sulfate, transfusion with at least 2 units of fresh whole blood, 2 liters of normal saline bolus, or IV noradrenaline. Keep sharing your responses and let us know what you think. Okay, keep responding. We'll be closing the poll shortly in the next 60 seconds. Okay, thank you for your responses. We'll be moving on to the next part of the presentation. Dr. Kalute.
Thank you. So we're looking at the emergency priorities. As we have already seen, our threat was in the cardiovascular system, the circulatory system, and those are the emergencies and the findings and associated risks that we need to worry about and try to address as fast as possible. So our immediate actions to be taken that we had in this patient was to establish IV lines, take off blood samples, do grouping and cross-match, and also we went ahead and did a blood transfusion. This patient received 3 units of whole blood and also received a unit of platelet. Then we gave tranexamic acid, 1 gram bolus. So after these interventions, we have stabilized our patient and want to establish more history of the patient. So in our sample history, the signs and symptoms were already highlighted that the patient had vaginal bleeding, which was associated with abdominal pain, had palpitation, dizziness, and indefatigability. However, I never had edema, no cough, and no difficulty in breathing. And those were our vitals on admission. She had no allergies. She was on medications, as she's a non-hypertensive. She was on losartan H and amlodipine, no other medications that were she was on. So her past medical history, she's a non-hypertensive for 5 years and she has been controlling with medications. Notably, she has an hypertensive clinic she's attending to. So the last oral intake was 4 hours prior to the admission. Events leading up to the presentation, our patient was well before, with no history of travel, no trauma, and no gender-based violence to this event. So from the secondary survey, our head-to-toe examination, the relative positives, head and neck, we had severe conjunctival and palmar pallor. From the chest, we had symmetrical chest movement, an SpO2 of 95% on room air, and normal percussion, vestibular breath sounds. For abdomen, notably, we had a palpable mass, which was pelvic in origin. The pelvic exam revealed blood clots and fresh blood from the vagina. Relevant negatives, normal musculoskeletal system, and we had cold extremities, however, no edema. On the skin, we never had any rashes, and it appeared normal. Yeah, so our working diagnosis was severe anemia, secondary to abnormal uterine bleeding. And the differentials we had for this were uterine myoma, abortions, and endometrial hyperplasia. For uterine myomas, we had supporting features of PV bleeding and a palpable pelvic mass, and we had nothing against that differential. However, for the abortions, we had support for PV bleeding, but this the lady had reported recent normal periods 2 weeks back, so which is not supporting for pregnancy. Endometrial hyperplasia, usually we don't get palpable masses on examination, and this patient had a mass.
Okay, and now we have our third poll question. What is the emergency bedside investigation for this patient? So we've been given a scenario of a patient who was nulliparous, presented with a 9-day history of vaginal bleeding. We've gone through the primary survey of this patient. We went through the secondary survey, and on examination, we established that this is a patient who presented with severe palmar and conjunctival pallor. On pelvic exam, you've noticed blood clots, and still in the examination, you identified that this patient was hypotensive. You've managed to perform your initial stabilization of the patient, and now you'd like to start performing some investigations. So what investigations would you do for this patient? Keep those answers coming. We have a couple of options. One is serum electrolytes and renal function tests, a urinalysis and a high vaginal swab, a CT scan of the abdomen and pelvis with contrast, and then a CBC and a pelvic ultrasound. Let us know what your opinion is. What investigations would you do for this patient? Okay, thank you for your responses. We'll close the poll and move on to the next part. Dr. Kalute.
Thank you. So went on to investigate the patient. We had the urine HCG done at emergency, and it was negative. Complete body count, where we had hemoglobin levels of 3.8, hematocrit of 12.8, and a platelet count of 173. Blood grouping, she was AB positive. And then we did a bedside ultrasound scan, which revealed multiple uterine myomas, with the largest measuring 7 by 6 centimeters.
All right, so right there we have our fourth poll question, which is what is the emergency specific definitive care for this patient? So this is a patient that you've taken history from, you've examined, you've done a couple of investigations, you have certain differentials in mind and a diagnosis. And now the question is, what specific management would you give to this patient? Keep the questions coming in the chat, keep the comments coming. Thank you for those. All right, so now we'll move on to the next part. Dr. Kalute.
So supportive management for the patient. This patient received blood, 3 units of whole blood, and also received a unit of platelets. So usually these patients come in and you have no blood at emergency or even within the hospital, and you want to do a volume expander because they have lost a lot of blood. So IV fluids, for this case, we didn't give because we had blood given immediately. She was lucky that we had blood in stock. Then we gave her tranexamic acid, 1 gram start. We supported her with oxygen, 5 liters per minute via nasal prongs. She had low abdominal pain, which we attended to with IV paracetamol, 1 gram 8 hourly. And she was started on ferrous sulfate. We had to put a urinary catheter to monitor the urine output as we do our fluid balance chart.
Okay. So we are launching one of our poll questions again, poll question 4. What is the emergency specific definitive care for this patient? Okay, so let us know, in your opinion, what care would you give to a patient that has presented in this way. The options are a myomectomy, estrogen replacement therapy, an IUD insertion, and then catheter balloon tamponade. Okay, a couple of you have shared some responses in the chat. Thank you for those. We'll be closing the poll shortly. All right. Thank you for your responses. Dr. Kadute.
Thank you very much. So for this patient specific management, she was to be followed up for hemoglobin levels, that is in the gynae clinic, and to book her for a myomectomy as her plan. However, such a case where you have a palpable mass originating from the pelvis, you need to explain to the mother also that there is a possibility of having a total abdominal hysterectomy done in case we are not able to save the uterus. Notably, this mother was nulliparous, so the team has to take caution that this mother is at least given a chance to have hope that he will deliver. So myomectomy is the first choice. However, may end up pushing to TAR in case things are not working our way. Then hormonal therapy, not likely in this case. The way the mother presented would not really based on hormonal therapy to help her out. So the patient was in the emergency unit for about a day and then transferred to gynae ward for monitoring for 2 days and was allowed home when she was stable with a post-transfusion HB of 8.1. Noted on ward, she was given more twins of blood. She was discharged on oral hematinics, that is faithful, 1 tablet a day to take throughout her visits in gynae clinic, and she was to be followed up, then booked in for myomectomy plus minus TAR. Thank you very much.
All right. Thank you, Dr. Kadute, for that presentation and giving us an insight of what a patient with vaginal bleeding can present with. Right now, we'll move on to the next part of our discussion with Janet taking us through the pre-hospital care of patients that present in this way. Okay, but before we move on, as Janet prepares herself, anybody in the audience that has a question, please feel free to raise your hand or type it in the chat and we'll be able to answer the question. As we do that, in the meantime, Dr. Kadute, one of the expectations that the participants had was to find out about the common presentation of patients with vaginal bleeding. So maybe you can just give us a brief summary of that as we wait for some questions.
Yes, thank you very much, Kathy. Common causes of vaginal bleeding, I'll talk from the perspective of Uganda and Kawempe National Referral Hospital. We have abortions. So when a mother presents with PV bleeding, the mindset that we have is that probably this mother is pregnant. And that's why you saw that in our investigation, actually, we had to do a urine HCG very fast to determine which type of bleeding we have. Is it pregnancy related or it's not? So the common causes are really pregnancy-related causes of bleeding, and those include the abortions, people present with ectopics that are having mild PV bleeding, but it really occurs. Then we have bleeding that occur later on in pregnancy that is caused by maybe placenta previa, placenta abruptio. Those are the common causes of emergency PV bleeding in our setting. But we have gynecological causes that include the fibroids, the way we have seen in our mother. We have causes, we have endometrial hyperplasia. We have malignancies that can also give you PV bleeding. And these include cervical cancer. It gives you bleeding that is very characteristic. If you take deeper history, you can get it. Then we have endometrial malignancy. They can also have plus or minus bleeding. Then we have polyps. They can also, they're associated with bleeding. However, in a normal lady that is not menopausal, always consult about the last normal menstruation period. You may be handling periods that are really heavy. Thank you.
All right, thank you, Dr. Kabute. Now we welcome Janice, our next expert.
Thank you so much, Dr. Catherine. Thank you so much, Dr. Flores, for the presentation. My name is Janice once again, and I'm here to take you through the pre-hospital part of responding to our case for today. So pre-hospital mainly focuses on taking care of the patients before they reach to the hospital, and what we need to prepare for pre-hospital care for this patient. We need staffs. So we need staff, we need patient prepared, we need equipment and medication. We shall need to know our mode of transport that we're going to use for this patient. And then we shall have our patient care form prepared for our handover. So for staff, what we need to consider in mind after getting a call, especially regarding to our patients that we have for today, we need to have our ambulance operator, or the one we can call a driver. We need to have an EMT or any trained personnel ranging from a basic EMT to a critical or emergency care specialty. But as we know, our Uganda, even a basic provider can respond to this case with a guidance from a medical officer in the call center or from the receiving facility. So how do we prepare our patient? So when we get a call and we reach on scene, usually this is out of the hospital, and our patient was at home. So when we reach at home, we need to first stabilize our patient before we move. Nevertheless, even if it is not at home, or if it is on scene, or even at a referring facility, we need to consider stabilizing our patients before we move. And this will help us to prevent clinical deterioration during the transport. So we need to manage our airways. We need to manage the patient of the breathing of the patient. We need to manage the circulation before we move our patient. So after stabilizing our patient using the ABCDE, we need to consider our monitors, and that is attaching the ECG leads, attaching the SpO2 probes, the BP curves, recording the baseline vitals, and this will help definitely to detect any changes in the patient status in the real time. Then the packaging, after stabilizing your patient, you've attached your ECG leads, SpO2, everything. So you consider strapping your patient from the stretcher so they shouldn't, because we know our Uganda, sometimes it is full of potholes. So you need to strap your patient so they shouldn't fall off the stretcher. If at all a patient needs ETT, or if you've intubated your patient and the ETT is not cuffed, we need to secure our ETT in situ to avoid extubation during the transport. We need to consider documentation of everything that we do on our patient, giving IV fluids. Our patient definitely was having PV bleeding, and she had a BP of 90/55. We shall need to resuscitate our patient en route, and here we're going to give IV fluids. We are giving 500 mils of normal saline, so we need to document. We shall need to give tranexamic acid 1 gram, and we need to document everything. in our PCF form. After documenting, we need to notify our receiving facility. You can use the call center to call the receiving facility, or if you're not using the call center, you can call directly to ensure the receiving team is ready upon the arrival. We need to make our patient to consent. If at all the unconscious, we can use the next of kin to consent because they have a right to reject transportation. So we need to consider consent before transport. So our equipment and medication, in our ambulances, we don't have crash carts, but we usually have trauma bags. So we have to come with our equipped trauma bags, and we pack our equipments through the airway, breathing, circulation, and disability exposure. So we have to have equipments and the airway, equipments for breathing, equipments and circulation, disability, and exposure that will help us in hydrating our patients, securing the airways, and medication. So our patient, according to the patient we have today, we are not going to give them fluids per oral because we are going to prepare them if at all the worst goes to the worst and they need an emergency operation. So we shall be using IV fluids instead of giving them per oral. And then we need to consider our aseptic techniques. So we need to put on our appropriate PPE and minimize infection. And then our IVs, if at all the patient is unconscious, we need to consider securing their airway during the transport. The medications here that we need to put in our trauma bag, as a must, we need to go with tranexamic acid, as we said. We need to have paracetamol, IV, we need to have some IV fluids, normal saline ringers, D5, D10, and if at all the worst comes to the worst, we need to have adrenaline, amiodarone. If at all we need to prepare for cardiac arrest in case of anything. We need to have our oxygen prepared and noradrenaline since we had our blood pressures crashing. Yeah, so as we said, we need to give our patient analgesia, and we were giving paracetamol IV 1 gram because the patient had pain, the lower abdominal pain. So we need to work on their pain management, giving them paracetamol, and we gave tranexamic acid during stabilizing our patient, and then keep the patient's position, can consider the patient's position of their choice or that is making them comfortable during en route. So after stabilizing our patient, making them consent, notifying the receiving facility, now call and dispatch has to dispatch an ambulance to transport our patient. This patient would benefit more from a type C ambulance, but because in Uganda we have very few type C ambulances, even a type B can respond to this case after stabilizing our patient. And the ambulance must also have an EMT or any health care profession on board to keep on working with the patient en route. That is monitoring the patient, reassessing the patient. As well, we can do a quick sample history to know any other underlying cause that is causing this patient, that is disturbing our patient. So we are using our type B ambulance. If at all we have a type C ambulance, it is also good to respond to our case. We are using our patient care form to keep on documenting whatever we've done in our ambulance or during the transit, and any reassessment done, any treatment given during the transit still has to be recorded under our patient care form to help us give a written handover, and it will help us to give an oral handover when we reach at the receiving facility. So when we reach at the facility, we need to hand over our patient, and we are going to hand over our patient using the ISBA, that is a communication tool that is recommended by WHO. So we've reached at our facility and we start with the introduction. My name is Janice from EMS. I'm handing in over a 41-year-old female neuroparas by names of JE, who presented with history of 9 days PV bleeding that started 2 weeks after her normal periods, involving expulsion of clots and fresh blood, with associated low abdominal pain, palpitations, dizziness, and easy fatigability. She's a known HTN patient who has been taking Rosatan H and amlodipine. His blood pressure was initially 90/55 on our assessment. He had a pulse of 108 beats per minute. And we managed to pad our patient using a gauze pad. We gave tranexamic acid 1 gram. We gave analgesia, paracetamol in particular 1 gram. And we're keeping our patient on oxygen, giving 5 liters via nasoplume. I recommend our patient to be reviewed by OBS-GYN and to have an urgent blood transfusion since she was paper white on examination. Thank you so much.
All right. Thank you for your wonderful insights, Janice. I think one of the key things that has stood out to me from your presentation is the importance of preparation and teamwork. As you mentioned, there's a lot that must go into preparing to receive these patients, right? From the medication that's to be given, the mode of transportation, the monitors, the staff that are involved. So I think that's really important. Another thing that you highlighted that I think was quite key is communication. The communication between the staff in the pre-hospital setting and the staff at the receiving site. It's important to notify the receiving facility about the state of the patient that's coming in and what needs to be done to optimize this patient and do the best to ensure we have great outcomes. If there are any questions specific to Janice's presentation, we can answer that. Okay, someone has added in the chat that in the IS bar, it's important to include the time frame under the R, which is the recommendation. So how soon you'd like the intervention, you'd recommend the interventions to be done. Thank you for that. Any other questions? Anybody who is in the audience that would like to raise their hand and ask a question pertinent to this part of the presentation? Feel free to raise your hand. Okay, I've also seen a couple of other questions related to the previous discussion and questions around management. We'll talk more in detail about the management of this condition. So without any further delay, I'd like to welcome our next expert, Mr. Wani, to take us through the nursing considerations in the management of a patient with pervaginal bleeding.
Well, thank you so much, Dr. Catherine, and thank you, Dr. Kalute, and also Janice, for the amazing presentations you've given earlier. Right now, we are at a point whereby Janice has brought the patient to the hospital, and it's most likely you'll realize that the handover will be to a nurse or to a midwife. Yeah. So, and that is where my point of focus will be. And I'll be discussing about what are the nursing priorities for this patient as the patient is in the emergency department. Ladies and gentlemen, my name is Solomon, to those who probably joined a bit late, and I'm a student at pursuing a Master's of Nursing in Midwifery, a Master's of Nursing specializing in midwifery and women's health, but I also have the privilege to teach at Lira University. And we jump in straight, first by looking at what is our nursing focus. Yes. The patient is here. So our nursing focus, one of them will be a rapid assessment of this patient using the ABCDE. We are fortunate that the ambulance brought. Sometimes they come from home, or they come on a border. without any prior assessment. Probably it's your first point of contact with them. So you need to rapidly do that. But also, in case you've realized that this is an emergency, like these cases, you have to call for help immediately. It's not a one-man show, so you need help. And then also, secondly, the nursing intervention, you have to ensure that you need to have a prompt delivery of the various interventions to stabilize this patient. We are going to discuss that shortly in the next slide, but we look at the continuous monitoring and reassessment. It is our duty as nurses and midwives to ensure that the patient is not only monitored, or the vitals are not only taken immediately from the arrival, or using the vitals which are the emergency team from the ambulance brought us with, could have changed immediately during the transfer. So you need also to ensure that there is continuous monitoring, but also reassessment of this patient in the emergency department. And fourthly, there will be early detection. You have to use all your senses and critically to detect any complications, but also in case there is need of any escalation, you therefore bring in the fifth focus, which is interdisciplinary collaboration. You need to involve everyone beyond the nursing and the midwifery team. You need to involve the doctor around, you need to involve the anesthetist around, but also you work hand in hand with the lab people in this case, because it's an emergency and you need results from certain lab investigations as soon as possible. So when we look at our nursing process. So our nursing process, or our nursing management, we have put it in terms of a nursing process. This makes it a bit easy for us to identify what a key priority in the nursing is and how we can immediately intervene. The first part of it will be assessment in the nursing process. So when we look at the assessment, the subjective and the objective data for this patient. One, the subjective is the patient has reported to you with PV bleeding already for 9 days and expulsion of clots and also there's fresh blood, she's bleeding and also having the palpitations. You've taken the blood pressure and there's hypotension of 90 over 55. As per the blood pressure, tachycardia setting with 108 beats per minute, and we see the oxygen saturation at 95. But we also realize that we can see that the patient is severely pain. So what is one of our key priority of nursing diagnosis is that there is inadequate fluid volume related to excessive blood loss. And this blood loss, we say it's due to the abnormal uterine bleeding. And we have evidence that by the prolonged vaginal bleeding, but also with the other key markers to it being the hypotension and the tachycardia. So in the emergency department, what is our goal for this patient that we have seen is having inadequate fluid volume? One, the main is to restore the adequate fluid volume within 2 hours. You need to do that as quick as possible. And what are some of the indicators we are going to use? The blood pressure. The blood pressure has to rise to about 100 to greater than 100 and over 60 or more, and have a heart rate. The heart rate, we desire to have a heart rate of less than 100 beats per minute. And now here comes in what we have to do seriously, the main task. The first is to establish or insert the 2 large bore intravenous lines. We are lucky that Janice has brought the patient and the patient already has the IV lines. Well and good. In case does not have, establish it immediately. And as you establish it, what is the rationale? Are you just going to establish it and leave it there? No, we need to obtain a blood sample that we are going to rush it to the lab for CVC, for grouping, and for cross-matching. But also this patient may need IV fluids or blood transfusion. So we are going to still to use the 2 large bore intravenous lines for that. And what is the other intervention? There have been more interventions. The other is to prepare the patient for blood transfusion and transfuse with the compatible blood group. So we know that certain times you may find you just don't transfuse anyone, but you have to get the consent from them as well. And you know, you can also, you the nurse will be responsible for taking this blood sample to the lab as well. But preparing the patient involves even counseling them and telling them why they need this blood. And in certain scenarios, if you may find there are certain probably religions which may not really desire to have the blood transfusion. But if you talk to them, well, maybe there can be a change of that. So what's the main purpose? The main purpose of that is to restore the intravascular volume and also improve the cardiac output of our patient. And then we need to position our patient in a supine position with the legs elevated. Dr. Carlota already highlighted earlier on that our patient was having a hypovolemic shock. And one of the other easy interventions we can do as we are sourcing for blood is to position the patient in supine with the legs elevated. Yeah, that helps. That the rationale for that is that it improves the venous return and therefore perfusion to the various vital organs of the patient. And then in case the tranexamic acid has not been administered, you have to ensure that you administer it. IV, of course, and it's 1 gram. Tranexamic acid is very, very helpful in helping to reduce the active bleeding by stabilizing the blood clots. Yeah, and then we have the monitoring of vital signs. It's very, very important. And how often should we monitor these vital signs? Every 15 to 20 minutes. So it's better if you have a monitor around and you've connected your blood pressure cuff and the other machines you have connected to the patient, and you're monitoring the blood pressure, you're monitoring the pulse rate, you're monitoring the respiration, and also the oxygen saturation of this patient. But also you continue, as you have intervened, you continue to monitor and assess the amount, the color, and the presence of clots in the PV bleeding. And that is also very important to help you detect any early shock or any worsening hypovolemia, but also to evaluate, very important, to evaluate the response to the treatment. And lastly, according to that nursing diagnosis, you'll have to evaluate. After intervening, you evaluate. So after 2 hours, you evaluate the patient, and probably in this case, you will see that the patient has regained her adequate fluid volume. And then you state what has been, because you have to document this. What is it? What is the evidence of that? The blood pressure of 100/60 or more, and the pulse rate of 90 to 100, but also the PV bleeding having reduced. It's very, very important that as nurses, as midwives, we need to document these things. And we are well aware if it's not documented, then it's not done. So when we look at our next nursing diagnosis, our next diagnosis could be our next diagnosis is here. It is right: impaired tissue perfusion. Impaired tissue perfusion related to reduced blood volume and evidenced by severe pallor, the slow capillary refill, which has been greater than the 2 seconds, the cold extremities, and also the low HB. And that we can really confirm from our assessment, which we got that from our assessment from the subjective data, the dizziness, the fatigability, the palpitation, but also the objective data we have got, which is which you can see the HB being 3.8 grams per deciliter and the respiratory, but also the oxygen saturation and the capillary refill and the pallor. So what is our goal? Our goal here is to restore the adequate tissue perfusion within 3 days. You know, restoring it means you have to give blood and do other things. So it is not something that just takes place instantly. You can give it a bit of some time, 3 days, and to also ensure that we reduce symptoms of dizziness, fatigue, and the palpitations that can happen within a few minutes or hours, and also ensure that our vital signs are stable. So what interventions are we going to carry out here? one is to encourage bed rest. Let us not let the patient keep on moving up and down. Oh, I have to go and buy this. Probably, if they don't have a caretaker, ensure, guide them, help them in getting that, in ensuring that the caretaker is around. Let the patient not strain in moving up and down. Otherwise, if they keep on moving up and down, the cardiac workload will increase, but also the demand for the oxygen will also increase. So the bed rest is very good in minimizing the cardiac workload, in conserving and reducing the oxygen demand. And then we need to administer oxygen therapy. And in this case, you can give as much as 5 liters per minute via the nasal prongs. And that will help to improve the tissue oxygen, the delivery of oxygen to the tissues. Yeah. And then also administer the prescribed drugs, the prescribed treatment. Here we have ferrous sulfate already prescribed. We have blood, which has been prescribed, whole blood and platelets. But also we realize that beyond the ones which have been prescribed, this patient is a patient with hypertension. So we need to ensure that she continues with her antihypertensives as well. And then also that really is basically to improve the ferrous sulfate. It helps in the iron, helps in improving the erythropoiesis, but also when we give the blood, it is very important in correcting the anemia of 3.8 grams per deciliter and reducing the dizziness, the fatigue, and the palpitations. Yeah, and secondly, with the fourthly, the intervention we have is to monitor the HB and the hematocrit levels. HB and hematocrit levels are very important parameters or indicators of evaluating how your patient is improving or evaluating the effectiveness of the treatment you've given. And but also we have to continue to monitor the signs, the vital signs that we talked about. Yeah. So after about 7 hours, you'll probably realize that your patient will report a reduced dizziness or palpitations, But then after about 3 days, 2 to 3 days, you'll realize that also the HB of your patient has improved greatly to about, in this case, it improved actually to 8.1 grams per deciliter. Then the vital signs becoming stable within the 7 hours. And our third nursing diagnosis that will require also serious intervention is the acute pain. When this patient reported, he reported with lower abdominal pain. So we have a nursing diagnosis of acute pain related to uterine contractions, as evidenced by patient verbalizing, I feel pain in my lower abdomen. So usually it's the presence of the clots within the uterines, within the uterus that really stimulates the uterus to start having the contractions. And so the patient will end up reporting that. So you just don't need to let the patient say, oh, please just bear with us. No, you need to you need to really intervene. Or don't say, just persevere. Intervene. Your goal will be to reduce the pain levels. Now, in this case, I've not put the patient pain scale proper at admission, because it's not a case I really participated in, but this is an eye-opener. When we talk about pain, we need to assess the pain. We need to assess this pain using a pain scale and rank it. What is the pain? It's probably out of 10. Just ask the patient, out of 10, what is your ranking of your pain? You get it? Yeah. And that will help you also later on in evaluating your pain management, the intervention you've given in managing your pain. So one of the other things is that the intervention is administered the prescribed analgesics, the IV paracetamol, 1 gram 8 hourly. Of course, we know the analgesics relieve pain, so it will help in relieving the uterine and the pelvic pain. Then also provide reassurance and a calm environment. Try to ensure that the environment is a bit calm. There's no noise everywhere. People are not shouting, screaming. Just imagine you're the one you're in pain and then there is a noisy environment, or they are pushing your bed here and there. It is not really good. So, but above all, we need to reassure the patient, talk to her, talk to beyond the patient, talk to the caretakers, reassure them. Reassurance reduces the anxiety-related pain perception. So it's very, very important that we really do reassure them. And just beyond, it's something that we usually don't do. And this message of reassurance, it moves beyond the nurses and the midwives. It moves also to the doctors. It moves to them as well. That let's reassure this. Probably if the patient hears from the doctor much more, then their confidence of getting better will be increased. Yeah. And then lastly, we say we position the patient in the bed comfortably. Let her lie on her side. Let her position herself in the bed in a most comfortable side for her. That reduces the abdominal strain. Sometimes, if you position yourself, if you lie on another side, probably the abdominal strain increases and you feel much more pain. And your evaluation, we expect this can be rapid within an hour. The patient will have reported reduced pain, but you also then have to tell us what is the pain scale that the pain has reduced to, and also the patient reporting improved comfort as well. So those are our three key nursing diagnosis and the nursing management, or in our nursing process. But one thing I have to let you know is that the nursing process and the nursing process here, it is continuous. It is not that after these three, you say, I have done my part. It is done. You have to keep on reevaluating what is the urgent need in this patient? How can we help? What goal can we set in? So you could have many other goals for this patient, including actually you talk about the nutritional. Since he has lost a lot of blood, we know that the nutritional intake is very important. So you have to health educate her about what kinds of food to eat in order to improve her red blood cells levels as well. That is very, very key as well. So this presentation has been guided by NANDA, and that is by the International Nursing Diagnosis, the definitions, which is this so far the latest, running from 2024 to 2026. And I really acknowledge that. And ladies and gentlemen, thank you so much for the audience.
Great. Thank you very much, Solomon, for that very elaborate presentation. From the things that you said, a key thing that has stood out to me again and again is the need to not only make interventions to manage the patient, but also to have targets in mind.
Yeah.
So as you are managing the patient and instituting your different measures, whether it's oxygen therapy, IV fluids, a transfusion, it's important to monitor the patient for improvement, which can be through the clinical monitoring and examination of the patient. It can be through the vital signs, it can be through the lab parameters, but also it's important to monitor for adverse effects. So we mentioned transfusion of patients. We know that transfusions tend to come with a lot of adverse effects. So to all the healthcare workers out there, please make sure that when you institute an intervention, monitor the patient and make sure your patient is responding to the intervention, and also they're not having any adverse outcomes that you can reverse.
Yeah.
All right. Thank you.
All right.
So right about now, I'd like to welcome our next expert, Dr. Jacqueline Akello, to take us through the management and approach to these patients with PV bleeding. A lot of your expectations were surrounded around management of these patients, approach to these patients. So this is a part that I think we're all eager to hear about. Dr. Akello, the floor is yours.
Thank you, and thank you so much for the previous experts for sharing. Are you able to hear me? So my work has been made very easy because, we are looking at the emergency setting, management of the patient in the sense of emergency setting. I've seen quite a number of questions and comments around that definitive management. the surgical approach, hormonal. But the disclaimer here is that we need to optimize this patient in order to move forward to definitive management of the end goal, and we've not managed the emergency. So this is really focusing on stabilizing the patient and managing the emergency, and then later on optimizing the patient for the definitive care, which may include surgery or the other medical components, which are non-emergency related. So we can have the slide come forward. So once again, I'm Jacqueline Akello, also a student, PhD student, but also teaching at Makerere University Department of Obs and Gyn. And I'm happy with this case because it's not our usual obstetric-related cases where we panic. This is just an eye-opener for us to note that even non-pregnant women die to vaginal-related bleeding. And sometimes, of course, these are not notified, reported, so we don't feel so much for them. But just to take note that this is happening in our settings and we need to take note of that. So let's go into the acute care management. And this, if you're the doctor in the emergency department, how would you approach this patient? My colleague has really delved into the nursing care, which is mostly what I will also talk about in the management. Next, we can move to the next slide. Yeah, so here we are focusing majorly on emergency decision making. When you're in the emergency department, how should you assess the patient? Which is the basic investigations, the bedside investigations that need to be done, the emergency management. But after you have optimized the patient, what is the disposition plan and follow-up of this patient? So the goal is to do what will save this patient's life within the first 30 to 60 minutes of arrival into the emergency department. Maybe before I get into next slide, the approach while in the department, there are quite a number of things that have improved care for patients with shock during transportation. And one of the options we have is actually the use of the non-pneumatic anti-shock garment in transit. If the patient is moving from probably picked from home by an ambulance, it's one of the things would you apply and it really improves the signs of shock before you reach the facility. But again, our facility, in Uganda, as already alluded to, we rarely have ambulances to pick patients from home to facility, although it is something we'd wish to move forward to. And I'm happy that this EMS assessment was done by SID Global, and the EMS department is working towards this call and dispatch center for even patients who are from home. So these are things we need to keep working into. And EMS department would love to have anti-shock garments in our ambulances as part of the equipment, not just for the maternal child health department. So while in the emergency department, I know we've talked about the ABCD, and we'll talk about this again and again. And in this order, a patient may have PV bleeding, but what will kill the patient might be the airway. And you see the rate, the sequel of death is that PV bleeding may not be the one to take you, but the breathing, if the airway is obstructed or if you're having respiratory issues. And PV bleeding can cause any of these to happen. For instance, what happens in the airway in a patient who is having PV bleeding? We know that when you're having vaginal bleeding, there is reduced oxygen delivery to all tissues, including the lungs. So you'll have a compromised airway. And that's why we emphasize airway, breathing, circulation in that chronology, because even death will happen. Airway kills you faster than the bleeding. This patient has had bleeding for 7 days. But if she has something obstructing the airway, it will take seconds to die. So respiratory distress, aspiration risk, especially if you have altered mental state, then you're at risk of aspiration. And you can have altered mental state in a patient with PV bleeding due to hypoxemia. So there's a lot happening beyond the vaginal bleeding in the systems that can make the patient go even not related to shock, all that. So we ensure patency, and usually the easiest is really to talk to the patient. If the patient is able to respond, even just calling out their name, then you know that the airway is patent. And you move on to the B, which is breathing. And in our primary survey, usually it's basic survey without equipment. Should happen within 15 minutes of arrival of the patient. So respiratory rate, SpO2, oxygen. I know we've talked a lot about oxygen. Even without knowing the SpO2, a patient who is bleeding needs to be connected on oxygen. Then circulation, we've talked about the signs of shock. Our patient presented with all the signs of shock. Cold extremities, the systolic blood pressure was quite high compared to the pulse. Someone talked about the shock index in the chart, which was clearly 1.2 or more. And all the other signs, the BP was 90, systolic, and the diastolic was quite low, and all these were pointing towards circulation. And then, of course, as we talk about disability, we want to assess the level of consciousness of the patient. GCS is a bit tricky, but we usually request that we use the AVPU scale. Is the patient alert? Is the patient responding to pain, verbal response, and all that? That's much simpler and easier to do than the GCS. But also, of course, it communicates the level of consciousness of the patient and the risk associated with airway and breathing compromise in a patient with altered mental state. And then you have to expose, you can see now we are looking at the bleeding last, but you have to expose and assess for this level of bleeding and then be able to move on. So from our survey in a patient who is bleeding, my question is, what would be the cause of shock would be the bleeding unless proved otherwise in the patient that was presented. Next. So what are the key red flags in this patient? One, we have ongoing PV bleeding with clots. We have the signs of hypovolemic shock. We have severe anemia symptoms, which were presented, dizziness, fatigability, and all that. And then we also had suspected structural pathology on abdominal examination. So which of those red flags would worry you the most? Okay. Let's go on. So definitely the shock would worry you. And so should be able to recognize signs of hemorrhagic shock. And I remember this was one of the poll questions in the beginning, which was the emergency signs. So the hemorrhagic shock should worry you because of the bleeding, the tachycardia and hypotension, dizziness and syncope. So you treat shock until proven otherwise. And the treatment of shock, we can move on to the next slide. We've talked about fluids. Okay, so before we go into the management, someone in the chat talked about how to take history. Again, the emphasis here is on the emergency care for this patient. The other detailed gynecological history, contraceptive history, sexual history, comes later on when you have optimized the patient is stable and probably thinking of definitive management. But in the emergency setting, we use the acronym of SAMPLE to take the basic history that will enable us manage the patient. And from our patient, we got the symptoms which the patient presented with. Patient had no allergies, but we were able to tell that the patient was on antihypertensives, which is the medications. The past gyne history, we know she's nulliparous, she's not had any abortions and all that. But also for every woman of reproductive age, the last normal menstrual period is very important. And we ask this, but do not conclusively rely on what the patient tells us. That's why we go ahead to test, even when they tell us the last normal menstrual period was yesterday. We still go ahead to test because there are lots of things happening, physiological changes happening in a woman's body that sometimes people confuse even a first trimester bleed as a period. So we have to go ahead and test and do urine HCG to rule out a pregnancy. And then, of course, events leading to the illness. So a brief, focused, what we're calling the sample history is very important for us to decide on the management. Okay. Next slide. So priority bedside investigations, we emphasize bedside We've seen patients die as they wait for scan. We've seen patients die as they are taking samples for CBC, especially in facilities where these setups are far away or they are not available and they have to be done from out. So we emphasize bedside investigations. Pregnancy tests should be done, again, in all women of reproductive age, and bedside. Point of care tests recommended, as already said, and then continuous vital signs monitoring, as already emphasized by the previous speaker. So first things first, we need the CBC or the full blood count, pregnancy test, and vitals. However, we do not want to do investigations as we wait to initiate treatment. So it is not a sequential way of managing, it is a parallel way of managing the emergency. As I take off the sample, I am resuscitating the patient. As I'm waiting for CBC results, the fluids are already running. It is not sequential that I need a CBC result in order for me to initiate treatment, or I need results for pregnancy test in order to initiate treatment. So it is parallel. You do the investigation as you treat the patient. There are some investigations that can be bedside if available. Like for instance, where this patient was in Kawempe, we have bedside scans. You just call the radiologist and they come and do for you the scan in gyne emergency. But we know there are some units where you need to refer patients to have a scan. So your clinical judgment is more important than some of the investigations like a scan, which you should be able to do later on when the patient is stable. I have seen patients die in the queue waiting to be done scan. And you know, there's no triaging. Literally everyone is bleeding. So the scan people do not really do triage of who has the emergency signs and all that. So if you have a bedside scan, well and good. If you do not have, your clinical judgment should come in handy, and then send the patient later on when they are stable for scanning based on the other previous bedside investigations. Next. Whoever is moving the slide, yes. So what is the emergency management? A lot has been talked about. Control bleeding, restore circulation, and restoration of circulation is through fluids, which fluids can be the crystalloids or blood. Correct anemia, prevent complications, and the emphasis here is parallel processing, not sequential processing. Resuscitate while investigating. When we were talking about emergency transfer in the ambulance, we talked about giving TXA. The nursing care has talked about TXA, and we are emphasizing TXA 1 gram. Early initiation of tranexamic acid saves lives. We have seen this even in PPH management, that this should be administered within 3 hours of diagnosis of PPH. And again, I'm emphasizing here that once you have diagnosis of PV bleeding, initiate tranexamic acid 1 gram as early as possible to control bleeding. So it is part of the emergency management, emergency drugs to be given. Now, there was a lot of questions around fluids, and we are emphasizing crystalloids. Now, we know that usually when you have blood loss, we talk about fluid replacement and then maintenance. And here we are talking about replacement. But in this patient, we are unable to estimate how much she has lost. Okay? So we use the parameters to replace the fluids. We give crystalloids as we monitor the pressures, the SpO2, and the response of the parameters by the patient. However, of course, there's a worry of volume overload. But when we do the trainings for emergency quick check, for those who have done quick check and emergency triage, we realize you can give patients actually up to about 6 liters before you worry about fluid overload. But we're saying in the first 30 minutes, in the first 1 hour, run 2 liters of crystalloids irrespective of HB. The other issue is when you have bleeding, it takes time for actual HB to show. So the HB usually get in an acute bleed is not correct. So we use the crystalloids to replace the fluids as we look for blood. And I'm emphasizing crystalloids, normal saline or Ringer's lactate, because not every facility in Uganda will access blood like Kawempe did for the patient we had. We know the issues of blood in our setting, and I want to believe this is not just in Uganda, but probably in Africa, because I've traveled quite to a number of facilities in Africa, and we don't have that easy access to blood. So even as we look for blood, we continue to restore the circulation through IV normal saline or Ringer's lactate. There was a question about why are we emphasizing IV and not oral. It's easier and faster to give the IV because as volume expanders than oral, which you have to first take, and then it is reabsorbed, and then it gets, from the stomach to the bloodstream. But also by the time the patient starts demanding for oral fluids, one, they are severely dehydrated, but also they have hypoxemia, and there's risk of aspiration as you give them to drink. So we encourage IV crystalloids as volume expanders as you look for blood. If you have blood at hand, then you're good to go. But then you'll have to activate the massive transfusion protocol, which also has its challenges. So again, fluids, particularly crystalloids, and then blood as you try to correct the anemia. Anemia, there are several ways of correcting. You can use the iron sucrose, you can use the iron ferrous sulfate after you have corrected the emergency and the patient goes on like the one we had. And then we have to prevent complications, and preventing complications comes with so many other things, infection prevention, everything we're doing, we have to follow a septic technique, okay? And all these. But you have to involve the senior team as early as possible in the management of the patient, in the decision-making chain for the patient. So there's a criteria for selecting blood, and I emphasize, please do not treat the numbers. We can move to the next slide. Do not treat the number, treat the patient. Okay, so for blood transfusion, the HB alone is not an indication for transfusion. We have seen patients being referred for blood transfusion without really trying to replace the volume that is being lost, and the patient dies along the way. So treat the patient, not the number. The clinical status of the patient matters a lot. Okay, so indications for transfusion when we have shock, ongoing bleeding, severe symptoms, but the emphasis is treat the patient and not the HB. Sometimes the HB is deceptive. You see the patient has HB of 7, but the patient clinically looks 3. So your clinical judgment is much more important than what you get because of issues of calibration and all the things that happen in the lab. We have lost patients because of confusion of results that we get back that do not match the clinical status of the patient. Most importantly is monitoring reactions and response. As you give fluids, as you give blood, what is the response in terms of the vital signs? Sometimes we've given fluids are not given appropriately. And so the response is what dictates how much we should give and when we should stop. Next slide. So disposition plan. Of course, this is in an emergency setting. So what you're handling is an emergency, but beyond the emergency, where should this patient go? There are settings where your emergency is the actual ward. There are settings where your emergency a department, like in Kawempe, we have gyne emergency department where this patient will be taken. And once the patient is stable, is transferred to gyne ward for definitive care. There's a saying that the best surgeon is the one that knows when not to take the patient for surgery and when to take the patient for surgery. In this case, we are not in a hurry with the definitive management, but we need to have a disposition plan for this patient. So again, the nursing care is the backbone of emergency care in cases of hemorrhage, and it has been extensively discussed. Nurses are the backbone of emergency hemorrhage care. So all the monitoring, transfusion, you realize giving treatment really lies around the nursing care. So admit if the patient is unstable, control the bleeding, transfuse as needed, and then a plan for definitive care. And then you clearly hand over to the next ward and follow up. And the next ward here I'm talking about, from gyne emergency, transfer to the parent ward and hand over with a plan of management. There's been lots of questions around the definitive management, and I'll talk through it briefly. Maybe we can go to that one. So for a patient with fibroids, there are quite a number of options in terms of management. It can be medical, can be surgical, can be mechanical, or radiological, depending on the severity, fertility desire. Our patient was nulliparous, okay, the size of the fibroids, the location of the fibroids, and even the setting. Okay, and even the setting, what is the facility able to offer? So medical, we have quite a number of hormonotherapy we can use. The GnRH agonists, the Mirena, the levonorgestrone intrauterine system, especially for patients who are close to menopause, because these shrink the size of the fibroid, and then they are able to get into menopause, and they don't have to go surgery. So it is really dependent on a lot of discussion with the patient. What is their desire? Is the patient still having fertility desires? Then you go for things like myomectomy, but also myomectomy, as already discussed, there's a possibility of going in for myomectomy and you end up with a total abdominal hysterectomy, depending on what goes on in theater. So the caution is, each time you cancel a patient for myomectomy, you cancel them for a total abdominal hysterectomy. But this is a discussion you have when the patient is out of danger. That's why we are insisting definitive care comes much later, and it's another discussion with the patient, depending on a lot of things, the type of the size of the fibroid, where it is, fertility, age, and all these things. There are things like uterine artery embolization that are offered in some centers, including IHK in Uganda, ablation. So depending on the setting, you can go surgical, you can go medical, you can go radiological, after having the discussion with the patient when they are stable and out of danger. The key take-home message is the ABCDs first, then early initiation of TXA and fluids, and of course here blood that saves life, and then it is team-based care. Team-based, you've seen what the EMT are able to do, what the nursing care is able to do, and actually very little to do with the gyne team, because their management comes much later when the patient is stable. Next. Next slide. So within the first 30 minutes of acute bleeding, what should be on your checklist? The ABCDE must be completed. You have 2 large bore cannulas instituted. Oxygen has been started if the patient is unstable. You have taken out blood for grouping and cross-match, but also CBC and all that. Pregnancy test done, tranexamic acid given, IV fluids started as you wait for blood, and then a senior clinician is informed, and continuous patient monitoring has been instituted. That is really, for me, what you do in the emergency department in order to save this patient, to optimize for the definitive treatment. Thank you so much for listening. This is guided by the WHO Management of Obstetric and Gyne Hemorrhage, ARCOG guidelines on acute heavy menstrual bleeding, as well as ECOG abnormal uterine bleeding acute management. Thank you. Questions are welcome.
Great. Thank you very much for that very elaborate presentation, Dr. Kello. I believe a number of the questions that were raised in the chat have been answered. A lot of the participants' expectations also have been met by this point in the presentation. In case you have any questions, please continue to share them in the chat, and you'll get answers to those as we go along. At this point, I'd like to welcome our next expert, who is Dr. Sarah, to just guide us through the session discussion and any question and answer, any questions that still haven't been answered.
Thank you so much. I think we have handled most of the questions that have been coming through. The other questions that are still pending are like definitive kind of care that is necessary. However, Dr. Okello has like put it rightly that this is emergency care for this patient. The patient that we have needed to first be optimized before we could even disposition them to their parent ward. So that is critical for all emergencies that are going to be receiving these patients and that are going to be coming through. The the critical part is stabilize this patient before you start putting other people on board. However, the teams that are supposed to be on board are the lab people should be informed prior to the patient arrival. The blood bank should be informed, and we would also prefer that while in transit, as Janice and the entire EMS team is transferring this patient, they give us a call prior and we prepare for this patient. In preparation, we will inform the lab that we have a patient coming, and if they have like that they have maybe taken off a blood sample, it would be good while in transit so that we rush the blood to the lab for blood grouping and cross matching. The blood bank is informed if we actually get to know prior if maybe it's like an intertransfer from, for example, one facility to another which has blood, then we would prefer that they do blood grouping and cross matching and they tell us prior to arrival so that the blood bank is informed to find out if we actually have that particular blood in our facility. Then the obstetrics and gyne should also be informed, but those ones will eventually come on board much later after we have optimized and stabilized our patient. The other questions that were coming through that I wasn't able to give quick answers then were about the definitive management and the GNR analogs in terms of management of leiomyomas, that's the fibroids. I don't know if Dr. Kello can speak into those briefly. So there was a question from Niwamanya, which was saying that what could be the appropriate indication for using GnRH agonist like lupropride acetate in management of fibroids, that is leiomyomas. Then the other question was if this patient who is a nulliparous had fertility desires, what was going to be the plan? And then the other questions that are still around that. I don't know. I think it would be right for Dr. Akelo to speak on that briefly. Hello? Is she still online?
Yes, sure.
Great.
Yeah.
So you can speak into that so that at least we have answers for the audience.
Great. So, GnRH analogs like lupramide are used to really reduce or shrink the size of the fibroid and control bleeding prior to surgery, only if you have very huge fibroids and you're planning for surgery. So they are not really independently definitive treatment. They are just used to reduce on the size of the fibroid. So they're given for a certain period to shrink the size as you plan for surgery, which surgery can be myomectomy or a hysterectomy. The other hormonal methods we use are things like I mentioned, Mirena, levonorgestrone intrauterine systems, which can be used in women who are close to menopause. So in itself, it's a bit of a definitive treatment because you're using it close to menopause and hoping the size of because during menopause the fibroids shrink on their own. So for GnRH agonists, they're used prior to surgery to reduce the size and control bleeding, and then you go for surgery. Now, for question 2, what if this patient, of course, the patient is nulliparous, had fertility desires? So here, the best option would be a myomectomy, which I think is what Dr. Kalute presented. you discuss with the patient and go in for a myomectomy. But even as you go in for a myomectomy, you still have to consent the patient for a hysterectomy, because in theater, we've gone in for myomectomy and found something totally different. And sometimes you fail to control bleeding. Fibroids are highly vascularized, and you have to actually remove the uterus. So yes, the consent process is a totally long process, because the patient has to consent for both myomectomy plus or minus hysterectomy, although the best would be myomectomy, depending also, of course, on the site of the fibroid, and the how many there are, and all those things. Thank you.
Great, thank you so much. There was also another question on the role of discharging this patient with tranexamic acid. Was there a role of discharging this patient with tranexamic acid?
So if the bleeding is controlled, we don't have to put them on tranexamic acid on discharge. No.
Then another question is the role of tranexamic acid in pregnancy-related PV bleeding. Is there a role? I think there is.
Yes, we have used, and there's a lot of work going on on the use of tranexamic acid. I think last week we were with WHO trying to revise some of the guidelines that have been shared during the FIGO Congress, particularly for PPH. And we discourage use of tranexamic acid prophylactically for, let's say you've had an abruptio placenta or placenta previa and you're giving in a pregnant woman. The recommendation currently is using in the postpartum period. So only if you have PPH, then you institute tranexamic acid as part of management. Although we've seen people giving it prophylactically during labor in people who have had missed abortion, IUFD, and all this. This is discouraged, and we had this meeting last week with WHO trying to refine the guideline, and still the consolidated guideline that is out, that was released during FIGO Congress in South Africa this year, still emphasizes its use only in the management of postpartum hemorrhage, so after delivery.
Great.
Thank you.
Great. That's a very, very elaborate answer. There is another question from Raymond. Let me read it out. I think it's a concern, and he seeks guidance. We have had different doctors with different opinions about the aggressive fluid management in cases of ruptured ectopic pregnancy with their scientific reasoning. Some advise against this, while others advise so. What's studied to be right in these cases of ectopic resuscitation? What do we know? What is known?
I think what is known and what we agree as clinicians is that in the case of ectopic, you have a TAP, and here we're talking about a ruptured ectopic pregnancy.
That's
you
right.
have a TAP, and you're bleeding intra-abdominally or
intra-abdominal.
Yes. So if you do rapid fluid replacement, you're basically pouring these fluids into the abdomen. Any little clot that was formed is going to be dislodged by the fluid. So what we recommend is that in ectopic pregnancy, even blood transfusion is not recommended prior to surgery in ectopic. We recommend that you put a cannula and put a slow drip to maintain the line, okay, the patency of the vessel, and then only do rapid fluid replacement once you have closed the tap. That means on table, when you have closed the tap, you've secured the rupture, then you can transfuse or do fluid replacement. But if you give the fluid before going to theater, you're basically worsening the situation, because all this fluid is just going through your ruptured vessels into the abdomen. So the recommendation is put the line, put a slow drip to maintain the patency, because if the patient gets into shock, you will not be able to actually secure a line. So it's more of securing an IV access and have a slow drip, and then you can do fluid replacement while in theater and you have closed the tap.
Great.
Thank you.
Great. I think there is a person who just put antibiotics and put questions. I think the question would be, what's the role of antibiotics in this case? Is there a place for antibiotic management or administration in this case that we handled today? I am just assuming that's their question, really.
You want to answer that?
Hello?
Yes, Dr. Jackie. Yes, thank you very much. I think there is a role of antibiotics in such a case. This is a patient who was bleeding for 9 days. The fear for infection is really high. We know that blood acts as a culture media. So if a patient has been bleeding, is at risk of antibiotics, infections, sorry. So we surely use antibiotics in this case for 5 days because of the fear that the patient is really exposed to the infections. Thank you.
Great. There is another person called Albert Ahumuza asking that what if this patient is actually in shock? And they're deteriorating with deteriorating BPs, do we still hold fluids? What would we do? I think anyone in the house can answer that. Anyone is open to answer that from the people in person.
Thank you. The issue of fluids, I think we need to do a case by case. Which patient are we dealing with? Now, for the case of ectopics, as Dr. Akela has already elaborated, we are going to be a bit slow. But the patients that you can really see that this patient was bleeding, but currently is not having that profuse bleeding. Now, like our case where we have uterine cause, which is more of because of fibroids. If you find that the patient has stopped bleeding, you can really repress the fluids as you're looking for blood. So I think for fluids, let's do case by case decision. Thank you. I think Dr. Kello can add.
So I think what Albert is asking is that the patient has an ectopic, right? Ruptured ectopic and is in shock. And he's asking, do we still withhold fluids? Yes. Apply the non-pneumatic anti-shock garment and withhold fluids until you're able to. Not withhold, but put your IV line and put a very slow drip until you're able to arrest the bleed. Because even if the patient is in shock and you're still pumping your fluids, you're not making it any better. It's not going to go into the intravascular volume to replace, as already talked about. But you can apply the non-pneumatic anti-shock garment, which is, by the way, in so many facilities. And we need to check our facilities because we have disseminated this across the country, especially the lower health facilities. Okay.
Awesome. Dr. Jeremiah, I think is asking something which is slightly off what we are discussing. What is the anesthesia? Which anesthesia is better for a patient with a ruptured ectopic pregnancy?
Okay.
Yes, for the setting of a ruptured ectopic pregnancy with signs of shock, the preferred mode is general anesthesia. Because we fear that when you use spinal anesthesia, you're going to push our vitals deeper. So we always select general anesthesia against spinal anesthesia. But we have also seen cases where we have used spinal anesthesia in ectopics that are just intact, and also leaking ectopics without signs of shock. We can go spinal.
Awesome. There are concerns on hemodilution and dilution of coagulopathies, but I think as Dr. Kello has said, hold fluids and prepare this patient to theater. You can only transfuse when you have the blood. But as we all know, we do not have blood readily available in all our facilities. Kawempe is the city center and it's close to the blood bank. Not all of us are having like regional blood banks. I am lucky at Yumbe we have a blood bank within the facility. We can easily access blood. But I'm imagining someone who is coming from Obongi, for example. They have to cross by ferry. By the time they are reaching here, I mean, you can give small fluid, but not so much as you tell us that this patient is coming and we prepare for them. So holding IV fluid is still the mainstream, I suppose. Okello will speak into this. until you reach a facility that can transfuse and have this patient taken to theater immediately.
True.
Any additions from you? I think that's it for now. Dr. Akela, are you still with us?
Yes, I'm here, and I don't differ from you, so I'm just saying true.
Yeah, so I think that's it from us, from the questions.
All right.
Over to you guys.
Okay. Thank you very much, Dr. Sarah, Dr. Akelo, and everybody who has participated in this Q&A session. At this point, we'll be going through the post-session questions. So this is the opportunity for you to assess how much you've been able to gain from this session. So please feel free to answer the questions so that we have a gauge. As we go through the post-test questions, I'd just like to give an opportunity to our experts to give us their parting shots. What's that one thing that you'd like the team to take away from this session? I'll start with Janice.
All right, thank you so much, Dr. Catherine. To me, I emphasize assessment, thorough assessment, and stabilization of a patient all the time. Use the ABCDE approach to assess your patient, which is going to help you to get the life-threatening condition and manage it. So stabilize the patient either from home, from the referring facility. Let's stop this thing of referring the patient like you're calling an ambulance, please come and take this patient. You don't want them to die from your facility. First stabilize the patient before you refer them. Use your ABCDE to assess the patient en route during your facilities and manage them. Thank you so much.
All right, thank you, Janice. So ABCDE approach is very key in the assessment and management of these questions, of these patients, sorry. Let's get final remarks from Solomon.
Wow, thank you once again, Dr. Catherine. Speaking to the nurses and the midwives, but also to the general team, my take-home message would be summarized in 4. 1, teamwork. Teamwork is very helpful. Call for help. Don't do it alone. Sometimes you could have forgotten something. Another team member will help you in it. All knows it and will remind you about it, but also makes the task easier. 2, assessment. Let's keep on assessing. Let's keep on monitoring the client or the patient as much as possible and document it. Don't just assess and keep it in your brain. Assess and document it. Then intervene in a timely manner. Interventions like Dr. Kello highlighted, tranexamic acid helps save lives untimely intervention within 30 to 60 minutes. Very important. So our interventions need to be as quick as possible, but also guided on evidence. Not just, and evidence keeps on evolving time and again. So we need to know the right interventions. And fourthly, which is also the last, is to evaluate. Evaluate the patient always. One intervention is not enough to take care of everything. Evaluate whether the patient needs another intervention or you need to escalate the intervention. Thank you.
All right, thank you very much for that, Solomon. So timely intervention, reassessment of these patients, and reevaluation and teamwork.
Yeah.
Thank you so much for those. The people in the audience, please continue to respond to the post-session survey. Now we'll have Dr. Kalute giving us his final remark.
Yes, thank you very much, Dr. Kathy. My take-home message for the audience is that for every mother that comes with PV bleeding, let's have an open mind to categorize this type of bleeding. Is it a gynecological? Is it obstetric? Because if it's an obstetric emergency, obstetric PV bleeding, you're dealing with 2 people. You have the mother and you have the baby. So categorizing the type you have will help you focus your management, and also it will put reminders to you that you may have to withhold some modalities because you have 2 in 1. The other thing is reassessment, which has been really emphasized by the nursing team. There are patients that come with normal vitals. More so, young women have been bleeding. They have not yet decompensated. So they come with normal vitals. They are stable. And you think these are patients that you can really ignore. But a patient who has come with a history of bleeding, you really need to do reassessment and reassessment every after a given time so that you are able to catch it early. Otherwise, we have had cases whereby a patient came in with normal BPs and the only chance we have to save them, they're already in shock. And the nurse has clear BPs taken, which were normal. So reassessment is really very important. Thank you.
All right, thank you, Dr. Kalite. So categorization and reassessment once again to ensure that you don't miss out on any life-threatening conditions. Dr. Sarah, would you like to give us your final remarks?
Well, from the emergency perspective, we like to resuscitate and stabilize our patients for any other department. So our emphasis is critical, and we emphasize optimization of these patients for the next level of care, which will be our disposition to their parent ward or to the place where they are going to get their definitive management. So for us, we will emphasize optimization of these patients, stabilize them, make sure that you have eliminated anything that could kill them from their ABCD and sample history so that they are able to continue with the rest of the management and also improve their outcome in terms of getting discharged and out of the hospital while still alive.
All right, thank you, Dr. Sarah. So optimization and stabilization of the patients. And finally, Dr. Akelo, please share with us your final remarks.
Thank you so much, moderator. I'll not differ much from Sarah. My final shots for any patient with an emergency. One is stabilizing the patient, optimizing before we think of surgery, before we think of final management, because the sequelae of management actually stems from emergency care. If you don't offer proper emergency care, that chances that you'll have complications excuse me, in the definitive management is very high. My other final shots is let's manage the patient and not the investigations. If I don't have a CBC, I should still be able to manage the emergency. If I can't access a scan, I should still be able to manage emergency. We've seen a trend where a patient walks in, PV bleeding, and the first thing is go and do a scan. And we've lost patients in that process because we are not using our clinical acumen to manage patients. We are using investigations. Our first line approach to patient nowadays is go and do a CBC, go and do a scan. And sometimes just how we talk to the patient, we are able to actually identify emergency signs by how we talk, touch, or interact with the patient. So let's manage the patient, not manage investigations. Thank you.
All right. Thank you, Dr. Akelo. Those were very powerful words from all our experts. So key thing is teamwork, management of the patient in front of you rather than the investigations and clinical finding and investigations, sorry. Please continue to respond to our post-test. We'll be ending it shortly. And then we'll have Dr. Kalute taking us through the right responses to the poll questions that we had earlier. Right, Dr. Kalute.
Thank you very much. So our first question was that from the primary survey, what is the emergency condition in this patient? We have got responses, and I think the majority, that's about 95%, have gone with hemorrhagic shock, and truly that is the answer. In our patient, as we have seen the evidence from the clinical examination and also clinical examination, it is evident that this patient was getting into hemorrhagic shock. Then the second one was that what are the emergency management priority for this patient? About 63%. They have gone with transfusion with at least 2 units of fresh whole blood, and that is the true answer for our case. Then we had question 3: what is the emergency bedside investigation for this patient? 87% have got it right. That is CBC and pelvic ultrasound scan. Our last question was, what is the specific definitive care for this patient? And about 87% have got it right. That is the myomectomy plus or minus total abdominal hysterectomy. Thank you.
Thank you, Dr. Kalute, and thank you to everyone who has participated today. I'd like to encourage all of us to turn our videos on so that we can take a group picture. Otherwise, thank you once again for sparing your time today. Thank you to our experts, both present in person and those online. It's been a very educative session.
You can give shout out to some people who know.
Yeah. All right. So this is our final session of the year. We look forward to seeing you again next year.
Good to see Joshua Ogal from Mwede
and Gloria.
Wish you a Merry Christmas from Mengo Hospital.
Merry Christmas to you all. We hope to have you again next year, and we shall be having a workshop where we shall get to recognize some of our people who have had the highest participation in this eco session, and also some small tokens of appreciation will be coming in. But also we only hope that from this session be able to translate the knowledge that you are acquiring into patient care, and so we can be able to improve patient outcomes. Because that's the goal really. I think we still have a few people that have had issues with their CPDs. Others don't know what the registration numbers are, but your registration numbers are actually on your licenses or on your full registration certificate given by your respective councils. So you can always go back and check if you're not very sure of what to enter, and please enter them the way they are appearing. If it begins with K, begin with K, because if you only begin with a figure, then you lose the CPD point, because we will not know where to assign you. As your name can only appear as long as you have correctly entered your CPD registration numbers. We hope that next year we shall be able to convince the respective bodies to at least give us a session on how to register for our CPDs, because I think quite a number of people have lost their CPD points throughout this year because of incorrectly entering your CPD numbers. And but we always do our due diligence to ensure that we actually give you your CPD points.